Good afternoon and well, good morning, very early morning here in the UK. This is our sixth in our series on the future of healthcare, and in this one we're turning to nursing as well, which an area of real interest for myself, a nurse by background. And this year, of course, is the year of the nurse as well. And it couldn't have been a tougher year, I don't think, for nursing. So it's going to be interesting as we talk to our guest this morning about the future of healthcare and perhaps the future of nursing within that as well. So on your screen, you'll see we've got a question and answer button at the bottom. You can click on that. You'll be able to put your information, questions in there. Don't raise your hand because it doesn't actually get the questions asked. So if you put that into the Q&A, we'll be able to do that for you. Going to introduce two speakers today. We have Karen Blake, Head of Clinical Informatics, Health Alliance, New Zealand, and Kate Rezenbrink as well, who's CNMIO from Bendigo Health, Australia. So a quick introduction, Karen Blake has more than 20 years in the healthcare sector. Karen's experience expands clinical practice in both Australia and New Zealand, as well as time spent in management and education. And please do read her profile on the registration page as well, because there's a lot of detail in there, which is really key. Informatics background as well, which is going to be very important in our discussions. Kate Rezenbrink is actually the Chief Nursing and Midwifery Information Officer, Bendigo Health, registered nurse again, extensive experience acute and aged care, and again, informatics background, informatician in the Australasia area and clinical reference lead for a digital health agency. So I'd like to introduce them. We're going to have a joint presentation from them this morning, and hopefully we can coordinate the slides well. But please do just shout out when those slides need to change. And don't forget questions and answers into that chat box, and we'll be asking questions in about 10 minutes time. Thank you very much.
Lovely. Thanks, Tim, for the introduction. Kia ora koutou katoa, ko Karen Blake aho. That's Tarao Māori for my name is Karen Blake, and greetings to all of you. So if you could move to the next slide, please. So I work at a shared service provider now called Health Alliance. So we provide IT services for the 4 Northern Region District Health Boards. So we're the top half of New Zealand, but servicing about 40% of the population. So really large kind of geographical area. I've spent over 20 years working in hospitals and now work with a whole lot of men in an IT shop, which is a pretty amazing experience. At the bottom of the slide, I do have a bit of a graph of our COVID cases in New Zealand, just for a bit of context. So you can see the peak of the pandemic for us, for our first wave was around kind of March, April. And I had to update my slides yesterday. Unfortunately, we've been 24 days with no active cases in New Zealand. And a couple of people left quarantine early on compassionate reasons to attend to federal. And we now have 2 positive cases yesterday, and we've got 1 positive case in quarantine today. If you can move to the next slide, please. So this is a bit of a timeline of New Zealand. We've been really fortunate that we got to learn from what was happening in the rest of the world, and I'll speak to that a little bit later. But our first case in New Zealand wasn't until the end of February. We did have a plane load of people evacuated from Wuhan at the end of January. Unfortunately, none of them were active cases with COVID. And you can see that we moved incredibly quickly from our first active case into community transmission, and then we went into lockdown incredibly fast, much faster than most other countries have done. We are really lucky that we're an island nation, and we were able to close our borders quickly. And we've been very strict about our border closures. Anyone coming into New Zealand has to go into a mandatory 14-day quarantine period. We've been really lucky that our case numbers have been low relative to other countries. We were originally tracking a lot like Italy, but we were able to stop that with 5 weeks of very robust lockdown. And we're now fully out of lockdown. New Zealand is now living and working and behaving and playing sports as we were before COVID New Zealand. We just maintain very closed borders because that's our weak link. As of yesterday, 2 new cases, and another case just reported this afternoon. Interestingly, we also correlate with the rest of the world that we have really high transmission rates in our healthcare workers, disproportionate to the rest of the population. Next slide, please. So Tim asked us to think about what were some of the key lessons that we learnt in Aotearoa, New Zealand in response to COVID. And probably the most important thing that we did was we learnt from other countries. And we learnt from what was happening in other hospitals and health systems, and from science and what was happening. And we took our own policy advice based on the evidence. And we didn't have politicians that were looking for political point scoring as we're seeing in other countries. So we were able to see what was happening, and that's one of the reasons that we locked down our borders so quickly and then put our whole country into lockdown so quickly, because we could see what was happening in places like Italy and in the United Kingdom, where you've got incredibly high case numbers and incredibly high mortality rates. The other thing that we did is we mobilised remote working pretty much within 48 hours. So we were getting some evidence out of Italy that really high rates of community transmission were occurring in GP and primary care waiting rooms. So we had notification from our Royal College of New Zealand General Practice that, and that was on Saturday, that by Monday, all GP appointments were going to be done via telehealth. So GP and primary care practices had 48 hours to move into telehealth. We had already started our work, our kind of back office functions working from home. By Monday afternoon, we had another 48 hours before we all went into lockdown, and we pretty much had another 48 hours to send all back office support staff in our hospitals home. So we implemented or scaled things like Microsoft Teams, Citrix, Zoom, and other collaborative tools within 48 hours to be able to support new ways of working. We were also able to start centralising our COVID-19 data across our region, so that we could start tracking things like ICU beds, PPE resources, staff resources, and anaesthetic resources, those sorts of things. And then we started sharing that data nationally. And that project was done within 3 weeks of kind of notification that we needed to do that. There was a lot of work to sort out our data because, like many other places, we had some pretty messy data that needed to be cleaned. But we had really beautiful dashboards built pretty quickly so that we could start having both a regional and then a national view of what was happening in our health services. And I think the other thing that was really important that we did was we were all really kind to each other as a country. So that our key messages would be kind, stay safe, and wash your hands. And it was really wonderful to have leadership from our kind of national government asking us all to be really kind to each other. And we certainly saw that at a community level, and we saw it at a national level and within our health services. Next slide, please. Next slide, please. Thank you. So I mentioned that we started remote working in the northern region. So there's some more detail in that slide if you want to have a look at it later, and I'll pass over to Kate.
Thank you. Thanks, Karen. Yeah, just setting the scene for Indigo Health and where we are in the world. So our state is in Victoria, and before I start, I would actually like to acknowledge that I am on Jarrah country, and I'd like to pay my respects to the Dja Dja Wurrung people, who are the traditional custodians of the land that Bendigo Health is on, and where our community resides. And I'd like to pay my respects to elders past and present. So there's a little map of where we are in Victoria, quite a huge geographical area, and I think we have about 14 sort of smaller health services, and we are the referral centre and trauma, and we still transfer people to Melbourne, but we are definitely a big sized hospital. Click through to the next slide, I haven't got the slides showing large on my screen, so the numbers are very tiny, but there's a picture of the atrium at Bendigo Hospital, a brand new building. So we've been here for under 3 years, but quite new, and the services that we provide are extensive. So there's only a couple of things missing there, but we work across acute care, community, and aged care. Next slide there. And just I thought some sharing some data on what's been happening in Victoria. So Victoria and New South Wales are the biggest states in Australia with the most cases, not geographically biggest, but definitely higher population than other states, and a lot of activity. So I know that I think I put those graphs in. If anyone wants to look up those, just Google and have a look. But we have a pretty amazing health department that is coordinating communication and providing updates to health services and to the community about what's happening in Victoria. And I think similar to Karen, we saw a very fast response to this, and a coordinated response led by experts from healthcare. So, and that's really been key, I think, in seeing the limit of spread, and coordinating care across Victoria has been they've been champions, really. And we had, as healthcare workers, a great fear, probably could only be on social media with my colleagues. No one else seemed to understand the criticality until things were really taking off. So we're all very much pushing for a lockdown so that we could protect our healthcare system and our healthcare workers. So we have a number of healthcare workers who've had COVID, but most of that, I understand, is people coming back from overseas. So we've also seem to be doing okay with our unknown community transmission, but we've got a number of outbreaks at the moment, and the tracing is time intensive, but it's working. So cross fingers that we can continue, and we can follow the path of New Zealand and open up a little bit, because these are very strange times. So next slide. I was digging around thinking about what has changed for our staff, and especially our nursing and midwifery staff, with this pandemic, and managed to find a photo from 1902, which is amazing that so many hundreds of years have gone by, and here we're doing a similar thing. We're wrapping our people and covering faces to protect our workers and our patients and their families. So quite interesting how we've come back around in a bit of a circle. We have a screening clinic here at Bendigo Health, and we're coordinating that beautifully. We've got some safety measures in place for our staff and patients and family members who need to access services, and it's working really well. We've now got thermal imaging screening as you come in the door. Next slide there. The other big change, I think, is telehealth. So having less than 200 telehealth visits in 2019 and almost cracking for 3,000 in a 6-week period, I think points to the infrastructure, the foundations that we had in place ready to go, and the capability of staff in switching modes in a way that protects patient care and provides the right kind of care at the right time. And we're now talking about how we can sustain this change, because in an area which is geographically large, really, do we want to go back to a situation where patients are travelling for hours to get to a 15-minute, 20-minute appointment? What works best for the patient, and how can we make sure that any changes that we keep or that we grow in terms of models of care work for patients and their families as well as the staff. So that's really been incredible, and as I mentioned, points to years and years and years, decades really of work to lay those foundations. So it took a crisis to get everyone working like this, and now we want to keep it. Next slide. So yeah, I was thinking again, this is another historical picture of our Bendigo nurses and potentially midwives. They're not named in this photo, but thinking about where we are, where we're in 2020, International Year of the Nurse and Midwife, and I think some of us are feeling like it sort of got hijacked, but we're seeing that nursing and midwifery at the moment is almost a dangerous profession. We've had reports of more than 600 nurses who've lost their lives because of COVID. So working to care for the patients in their care and contracting this virus. So, we're reflecting on that as a workforce, and we're thinking about how we can realise the value of nursing. What can we do in response to this pandemic and this way of working, and where are the opportunities for nurses and midwives? So digital health is one of those fantastic opportunities, and of course that's the background that Karen and I have. So we thought, what are some of the questions and next steps, and how we can have that discussion today. I'm really looking forward to it.
Thank you very much. Thank you. So, reminder, questions, they're coming already into our question and answer panel. We're going to pick some of those up in a moment. This is my opportunity to ask some questions, which is great. This pandemic has disproportionately impacted nurses, particularly in the Black and ethnic minorities, and we've seen that across the globe. You mentioned this briefly in terms of the impact in nursing. In the Year of the Nurse, we should have been celebrating. It does feel like it's been hijacked. Do you think that this is going to impact our future resources? Do you think less nurses are going to want to come into nursing profession in the future? With two of you, I perhaps should pass this question directly to one of you. Karen, can I start with you on that question?
Yeah, I think that's a really interesting question, Tim. And we know that during pandemics that Indigenous vulnerable populations are more severely affected. So, and that's going to include Black and other minority groups. And we certainly see that in New Zealand with Māori and Pacifica peoples. So there's been a lot of work that we've done and put a lot of extra resources into our Māori and Pacifica health services and in testing and designing systems and communication and processes for Māori and Pacifica. And we've done that by involving them and them doing that work for themselves with really well resourced. We are also seeing that happen disproportionately in nursing. And I think it's a really interesting question about, will this impact more people wanting to enter the profession of nursing and midwifery? And we've seen in New Zealand really high rates of applications for people wanting to join our police force, to the point where they've just had to close all registrations. And I suspect that we're going to start seeing the same thing in nursing and midwifery and in other parts of the healthcare sector, as we see other industries like tourism and hospitality and the retail sector absolutely decimated. And we're only at the beginning of a recession that's going to impact globally. People might start looking towards more secure forms of employment, which could be in public service, which will include nursing and midwifery.
Okay, thank you. And turning to digitization of the health record, in some respects, New Zealand had good documentation informatics in place already, which is noted by your positions and roles. Kate, what difference does it make in terms of the track and trace service having really good health records digitized at this time?
Thanks, Tim. I think it's critical. So those of us in digital health and working in healthcare, we know that services are often fragmented, and that continuity of care, the sharing of patient information, between jurisdictions is really challenging. So they're actually the aims of digital health to connect care and seamlessly integrate following a patient so that they can move through the right information goes to the right people at the right time. So digital health, is the opportunity to sort of respond to the issues we're seeing. So I think the interest has definitely been switched on. I guess the concerns about privacy and security come to the fore, but the benefits are much stronger, and I think realisation of that is shifting people's focus. So telehealth and GP appointments, but beyond that, how we share information. Do we need to fax? I'm really excited when I hear those kinds of questions. Why are we still faxing, especially now? So that infrastructure, that we've got a national approach to some of that, and working with health services and of course across the private sector to make sure that we're all connecting in some way. And it's rapid. The changes have been really rapid. So one of the problems, I guess, is funding and models of funding. So the barriers which have been identified need a comprehensive and complete engagement with by everyone who's involved.
Thank you. And Karen, in terms of this shared record, I mean, we've got a North, we've got a South Island, we've got nurses working across, we've got people who are coming through the borders. Has there been an increase in the communication from the different hospitals as well?
Absolutely. So a huge part of my job is around working on interoperability. So getting disparate systems to work together and sharing data and information across district health boards. So with in that kind of first week of mobilisation, we launched and completed a really large project to share information more effectively between our hospitals and primary care. So we had previously been very good at sharing information from our hospitals on discharge to general practice to say we've looked after your patient and we've discharged them, and this is the medication that they're on, and this is a follow-up that needs to be provided. But what we weren't very good at doing was consuming primary health information. So that project was spun up and completed really quickly, and we're now looking at sustaining that because we need to start being able to lock in these changes. And we did a lot of this work with security dispensation. So we now need to go and do some retrofitting to make sure that we're fit for purpose moving into the future. We also had some of our gaps highlighted. So we have been wanting to implement a health information platform for the past 3 years and haven't been able to get the funding for that. And the lack of a true health information platform with a great data lake was certainly a weakness for us during the COVID mobilisation. And identity and access management has been another gap. So that as we're moving into telehealth visits and wanting to share information across health systems, we need to know who people are and who we're sharing the information with. And identity and access management is something that you need to invest in quite heavily. People don't get very excited about it. A lot of clinicians don't understand it. And it's really hard to get people to commit millions of dollars to sorting out identity and access management. But those were a couple of the foundations that we've been missing, and we're now doing some work to try and resolve that, because what we know is that pandemics are increasing in frequency, and if people think that this is the last pandemic we see in our lifetime, I think they're sadly mistaken. And we also, in New Zealand, we've had a mosque shooting, we've had Whakaare White Island eruption, and a large earthquake in Christchurch and in Wellington that put a lot of stress into our health system. And we need to learn from the past to make sure that we're ready for our next state of emergency.
Yeah, thank you for that. We're getting some questions, lots of questions coming in. I'm going to turn to some of those in a moment. One of the areas around education, though, I think is key. We know that nursing in New Zealand is it's modern. Nurses are well trained. Other areas of the world perhaps don't have the same levels of nursing, but also we've seen many countries in the world actually bringing student nurses early into practice because of this pandemic. How do you, as nurse leaders, see education moving forward for nurses, both on the front line who are actually physically caring, but also for our students? How's that changing? Perhaps Kate, do you want to start?
Look, I think it's really going to be an interesting space to watch. We know that that our workforce here is highly educated and continues to push boundaries, I guess, of nursing practice. So we have about 1,500 nurse practitioners in Australia and many thousand advanced care practice nurses. So, but sometimes the catch up is that, you know, we're investing a lot in education. Education is actually expensive for nurses, but are they being used to their full potential? Are they realising their full potential in the models of care that we've got? And how can we fund nurse practitioners and advanced care practice nurses because they can help with bridging some of the gaps that we see and making sure that everyone in the community has access to good care. So, you know, education is definitely more pathways than they were, but the fights are almost the same that we're facing. I think there's much more interest in collaboration. So, with those models of care, working with nursing groups around the world, which is what we actually do in digital health. I mean, I'm in a group of chief nursing information officers across Australia, and there's 25 of us. And we're thinking about these questions about how can we build capability, especially in digital health, and how can we open up career pathways in all sorts of nursing specialties.
Okay.
So exciting, Kate, to hear you say that there are 25 of you in Australia. When I was working in Australia, there were 6 of us, so it's just wonderful to see the growth in that sector.
Yeah. And Karen, do you think that the advent of the telehealth explosion will encourage some of the nurses to extend their skills to practice more in that space as well? Do you think that's here to stay?
I absolutely hope so. You know, nursing is and midwifery, you know, we're in an opportunity to help transform the health system. COVID has accelerated these changes, but, you know, we have responsibility as a profession to sustain and maintain this into the future. And we are the largest health workforce. And if anyone's going to do it, I think it's up to us to help drive that change forward. Thinking about education, one of the gaps that we've identified is around digital literacy across our healthcare sector. So I think one of the challenges that we've got in the future as we become a more digitised workforce is how do we start enabling our existing workforce to really embrace new ways of working. And, you know, I think that for people that get into it and want to start then looking at informatics, that's a really exciting profession to get into.
Excellent. Thank you. We're just going to take a short break as we do a poll. We're going to put this on the screen for everybody in our audience to answer. If we can just pop the question up on the screen for me, I'll be able to read it. Thank you. So COVID-19 has highlighted the importance of nurses in care delivery. What do you think the key changes in nursing in the next 2 years, and you can choose 2 in this multiple choice question. So what do you think the key changes will be in nursing? Increasing nursing leadership opportunities, field of nursing informatics will be more prominent, more nurses will choose to specialise, nurses will be taking a more active role, better funding, or new approach to framework delivered for nursing practice. I'm going to leave that on the screen for a minute or so because you'll need to read through, but we're really keen to get your answers on this. I've had some very interesting feedback over the last few days as we've been around the globe talking to people. And in many respects, we were talking with Korea yesterday, again, a country that has managed track and trace exceptionally well and has had very low incidence of mortality as a result of COVID-19. but interesting lessons learned as well. And I think one of the key messages that you've been saying is around the messages learned as well. And Korea learned from their MERS incident many years ago, but it really did change the way that they digitized healthcare within that space as well. So we're going to close the poll in a moment once we've got enough answers. And then we're going to start to turn towards our questions, which are coming in at the moment. So in fact, as we come back, we're going to be asking you, particularly within New Zealand, COVID-19 is, this is from Jade Owl, by the way, from the questions, it's pretty impossible to completely eliminate COVID-19 within this year, even with a new vaccine. And it's impossible not to open the borders. Are there any measures in place? So I'm going to come back to that question in a moment. Let's have a look at the poll. The field of nursing informatics at 52% is our highest, followed by a new approach and framework developed for nursing practice. And nurses will be taking a more active role in delivering care and decision making. I really hope that's the case there as we go forward. Thank you for those responses. And so Kate, impossible to close, to eliminate COVID-19, hard to maintain borders completely cleosed. What measures can be put in place to counter the influx? And as you mentioned earlier, the 2 cases that have come into New Zealand in the last few days have caused a massive track and trace operation as well. So how do we deal with this?
So we have definitely a world of and nurses moving around the world. So there are countries which seem to be a source of nursing workforce and nursing labour almost. So I think we need to make sure that the more well-off countries can support other countries to develop their nursing workforce, and these are part of the World Health Organization goals actually to ensure equity and access to healthcare. So support nursing locally and grow our workforce. We've got an ageing population of nurses in Australia, so that kind of replacement issue is always there as well. But yeah, this is interesting. I don't think we're any of us are really sure what will happen with borders around the world. I think we're really in the peak time, but we're going to see this just bubble along now. And you know, I'm as interested as everyone in finding out how a vaccine might work and if we get there. So there's really great document that the World Health Organization has done about placing nursing into a sort of I think a worldwide lens of healthcare. And investing in nursing to invest in community health and population health.
Thank you. And I think actually this turns to Alicia Chow's question in terms of the, whilst in this year of the nurse, how will nursing leadership evolve? And I think your roles within New Zealand, senior roles in nursing, that doesn't occur everywhere across the globe at the moment. So how do you think this pandemic may impact nurse leadership in the future? Perhaps Karen.
I think that's a really interesting question, Tim. People like Kate and I don't get into our roles by accident, and I think that you really do need to advocate for yourself in these roles, where often these roles you find out about them through networks and by becoming a person of influence. And we all have our own ability to become influential. That, you know, being a leader doesn't mean that you necessarily have the title to go along with that. And how do we lead from the bottom up? And I'm a really big believer in kind of grassroots movements and people demonstrating leadership across all aspects of nursing and midwifery. You know, there's amazing new graduate nurses who are leaders. You know, you don't have to have the job title to do that. So, you know, I would really challenge, you know, nurses and midwives that are listening in about how do you start embracing leadership within your role, and how do you start demonstrating influence. and how do you start positioning yourself so that when the next job, you know, with the title comes up, that you've positioned yourself to be able to apply for that.
Thank you. Leanne Raven, so Karen Kate, how has the technology helped during COVID-19? What areas of digital health should we be focusing on to improve care quality for patients? Kate.
I think Karen mentioned before, sort of I think you mentioned telehealth and virtual care and sort of wrapping things around a patient. So we're looking at those opportunities. I think just that clinical communication, providing care remotely is obviously the next big thing. But perhaps building on the foundations that we already have and trying to solve some of the problems that we already have. Interoperability, as Karen mentioned, is a big one, and it's, as I said before, it takes a number of different parties to come together and solve it. So, but trying to keep people aging at home, aging in place, and providing care in the home. I think most care actually happens in the community, not in hospitals. But we've been really hospital-centric in our investment in digital health and technology tools and infrastructure. So I think we need to shift back out. And one of the questions I had is, where is your front door? Can we reimagine the hospital front door and make it the patient's own home and the front door there? So rethinking about how we do care.
Just a reminder to use the Q&A box. We can't respond to raised hands, so if you want to ask a question, please do put it into that. Christopher Goko, I'm going to kill that name, sorry, Gokoko, said, who owns the patient records when it comes to teleconsultation? Is it the hospital? Is it the teleconsult application? Or do you see a shared record within New Zealand? Where does it sit now? Karen.
So I don't know that we've necessarily answered that question very well at the moment. So we've got a piece of work that still needs to happen to record the telehealth visit and then store that as a digital file within the patient record. I absolutely believe, and it's supported by legislation, that all information is the property of the patient. We're merely the custodian of that information. And I think, along with interoperability being one of our next challenges, I think the other challenge that we need to think about is how do we get more information about people's healthcare delivery into the hands of the patient and consumer and into their family and whānau as care providers. So we need to stop thinking about data and information being the domain of the health system, and it certainly should not sit within the application. Telehealth providers have no business holding on to patient information. We need to make that available for patients to have sovereignty over their own information.
Lovely, thank you.
I just want to say, Tim, I totally support that. That's, if I could pick one theme that really colours my nursing career and why I got into digital health, it's making sure that patients have ownership of their healthcare. They're more invested in getting to good health than anyone in the team, and they are the continuity through their own healthcare. So can't stress that highly enough. That's terrific.
Thank you. Sally Duncan, there's interesting here. So re-year of the nurse on reflection, I think Florence planned it this way. She says how very much can be done under the spirit of fear. I do think that we have pushed digital health forward. We need to transform education, be recognised in our speciality, and advocate for the CNMIO roles to help drive this. What are your thoughts on this CNMIO type role? Karen, what's your...
Thanks, Tim. So I've been a Chief Nursing Midwifery Information Officer. I was lucky enough to be the first one in Australia. I am a midwife by trade. And my current role in New Zealand, I'm functioning as a CNMIO, but there are no CNMIOs in New Zealand. New Zealand's gone down the track of having Chief Clinical Information Officers. And I do not know how many times I need to continuously challenge the system in New Zealand that the role does not always need to be appointed in by senior medical doctors. All of the CCIOs in New Zealand are medical doctors, and it's my aim within my lifetime that that's going to change. We need more nurses to become really engaged in informatics and to have a loud voice, along with people like myself and Kate, who are saying that we need to have nurses, working alongside all of our clinical colleagues, including allied health, so that we do this in a collaborative, interdisciplinary way. But I'm a very big supporter of the CNMIO role, and for nurses and midwives becoming CCIOs and allied health professionals.
And Kate, your reflections on that particular role and the future?
Oh, I love that quote from Florence Nightingale, because she really is one of the original nursing informatics specialists and pioneers, and really it's important. Her legacy is really important because she used data to show how we could change healthcare and save lives. So totally support Karen's comments about that. One of the problems we have is that there really isn't a category, a specialty in nursing that is recorded. So we need to make sure that when we do our registrations every year, that we record nursing informatics as its own specialty, because we can't actually track and build our digital workforce and have nursing included where it needs to be if we can't see the numbers. So at the moment, all of the nursing informatics people that I know select other. So we really don't have sight of how many of us are there, and actually what kind of roles we have and where we work, and that's really important for building the workforce capability to solve some of the problems that we're seeing.
That's a really interesting point, Kate, that we don't know how many nurses and midwives are working in informatics. In New Zealand, we've got a clinical informatics leadership network with 370 clinical informaticians across all disciplines. And about half of those are nurses and midwives.
Yeah. So increasing numbers. Now we're coming towards the end of our time. I just got one question to go back to. Jade Orr also asked in this way, any changes to the hospital operation beyond COVID, the roles of nurses, need for retraining. But really, just in 30 seconds, first Karen and then Kate, how would you see the future of nursing, the future post-COVID?
Look, I think we're at an incredibly exciting time. COVID has accelerated change in the digitisation of our healthcare. We've seen nurses and midwives become essential workers, and our role within the health system has become incredibly front and centre in the public's mind. I'm really excited about what the future is going to bring, and we need to position ourselves so that we're ready for what comes next.
Kate.
Great. Well, I think the next big thing for us is showing up in the nursing, in the digital world as nurses. So using data. One of the questions there was about data issues. We can't compare nursing with nursing if we don't have data. So standardised nursing terminologies will be really important, so we can start tracking what it is that we do and how our work impacts on healthcare efficiencies, costs. But yeah, that's my thoughts.
Thank you very much, and thank you to both of you for today. It's been really very insightful. Sorry if I didn't get to the questions that have come up. We are back next Wednesday with Pavi Solo from Finland. We're going to be looking at the improving the patient journey beyond the hospital with digital services. Please do register. That's going to be at 8 p.m. Singapore, 1 p.m. British summertime, and I don't even know that time zone, 10 p.m. I'm going to have to think of that one. I presume that's Finland in the European zone. So thank you very much for joining, and look forward to meeting again next time. Thank you.
Thanks, Tim. Thanks, Karen.
Thanks, team.
Thanks for all the great questions.